Hey guys, it's Christian. The goal for today is to give you absolutely everything that you need to know about Class 1 antiarrhythmic drugs. Antiarrhythmic drugs are often dreaded, especially Class 1. It's notoriously known as the hardest subcategory of antiarrhythmics. I promise you it's not that bad. We're going to talk about it in a way that is intuitive, going to give you all the high-yield information you need to know. We'll give you practice questions as well, so that you can check your comprehension. It's going to be a great time. I promise. Let's get started. Okay, so in order for us to even talk about antiarrhythmics, we need to understand what an arrhythmia is, and we can use our operational definition of an arrhythmia as an abnormal rate or rhythm. Sometimes it's both, sometimes it's just one or the other. Okay, so the big picture idea here is that for patients that have these crazy arrhythmias where they're symptomatic, we usually got two options, Edison or medicine. This depends if the patient is stable or unstable. So I got two rhythm strips here, for example. This is SVT or narrow complex tachycardia. This is wide complex tachycardia or monomorphic VTach. If my patient is shocky, so they're hypoperfusive, so they have a low BP, maybe they're cyanotic, right? They have altered mentation, maybe they have ischemic chest pain. If they are unstable, they get Edison, they get cardioverted. We put the pads on them, we synchronize their QRS complexes, we deliver a shock that's timed to recalibrate the rhythm, right? That would be Edison. Again, synchronized cardioversion, not the same thing as full defibrillation done to a patient without a pulse. Now, if they're in one of these rhythms or any type of arrhythmia and they're symptomatic, but they're not unstable, right? They got a good pulse, they have a good pressure, then we can do medicine. And so that's what we're talking about here, these antiarrhythmic drugs. Okay. In order for us to even get to our antiarrhythmic drugs, we need to have a good understanding of our myocyte action potentials as well as our pacemaker action potentials. So please take a moment and pause the video to review this if you are not fully comfortable or confident on these, or else everything else won't make sense afterwards. Here is our slide here on pacemaker potentials. Again, make sure that you fully understand this, what channels are open, what channels are closed, what each phase means, or else the antiarrhythmic drugs won't make sense afterwards. And of course, shoot me a text message if you need clarification on any of this. Okay, here's them side by side. A big takeaway here is that pacemaker cells exhibit automaticity because of those funny current sodium channels on phase 4, which means that they can stimulate themselves. These cardiac myocyte action potentials do not exhibit automaticity, so they need to be stimulated externally, either from other cardiac myocytes or from receiving those positive ions from those pacemaker cells. So recall that all of these positive ions here can be shuffled over through gap junctions to trigger this depolarization here in phase 0. So just understanding those are a prerequisite to understanding how these antiarrhythmic drugs work. Okay, note that you'll see here how this action potential is kind of asymmetrical here, right? It's kind of asymmetrical. It's uneven. In fact, you can kind of even call it odd. And because it has an odd shape here, that's how I remember that antiarrhythmic classes 1 and 3, odd numbers, affect the cardiac myocyte action potential. Look at this figure. It's kind of even. Because it's even, that helps remind me that classes 2 and 4 are associated with pacemaker potentials. Okie dokie, let's get started. We need to understand that all class 1 antiarrhythmics are sodium channel blockers, 1A, 1B, 1C. And here are our three friends. We got a double quarter pounder. I'm from New Jersey, that's how we say it. Double quarter pounder. We got a lettuce and mayo with un poquitito sombrerito que está llevando un poquitito sombrerito acá. And then also 1C, which is our fries, please. Okay, those are how I remember the drugs. That's how my brain works. I'm sorry. Now, my goal is that I'm going to rearrange these in order of strength. So 1C, 1A, 1B. And I'm hoping that these eyes pierce into your soul so that when you lay down, go to bed, and close your eyes, you will never forget the subtypes of our class 1 antiarrhythmics. Okay, I put them in the order of C, A, and B because that goes the strongest sodium blockade to the weakest, and all of them are in a cab because it's C, A, B. All right, let's take this taxi cab, let's go and let's get started. Okay. Type 1C, which are our two drugs, Fraz, please, and our cab here to remind us that this is our strongest first, are flecainide and propafenone, right? Propafenone, I don't even know how they came up with that name. If you can't pronounce it, you shouldn't prescribe it. It's not a great clinical drug. Okay. Anywho, what is the main effect here? We know that it affects sodium blockade. In fact, it's the strongest one. So where do we have sodium channels? At which part of the action potential graph? It's going to be phase zero. And so this phase zero, where it was here in the normal myocyte action potential, we've now slowed this down. We've slowed down this phase zero, and we've slowed it down pretty strongly. We've slowed it down pretty strongly, the likes of which we've never seen before, right? And because of that, the slowing down of this phase zero, we've prolonged our QRS complex. So I just want you to make this association here that when I slow down this phase zero, I actually make the QRS complex on the EKG longer. Okay? All right. When I think about that QT interval, I'm thinking of phase three. If I were to move phase three, that would prolong the QT interval. That's not what we're seeing here, but kind of just note that in your mind if you didn't already know that. So what's the big effect here is this prolongation of the QRS complex, QT, meh, primarily because of this strong blockade of sodium channels, so the sodium depolarization takes a little longer. However, my total time of this action potential duration doesn't change. So it's super important to know that this is the only antiarrhythmic type 1 drug, type 1C, where the action potential duration does not change, and it has the strongest risk of prolonging the QRS complex. It has very slow unbinding. It has a strong use dependence. I'm going to talk about that in the next slide. But because of its strong use dependence, it has limited clinical use. Look at the CAST trial to see more. Basically, what that means is that outside of being used for reducing AFib, it's a really horrible drug that can cause arrhythmias to patients, if they're not in pristine cardiac condition. So in order to even give this drug, these patients need to have a normal ejection fraction. They can't have a history of an MI. Okay, what the heck do I mean by use dependence? What we mean by this basically is that some drugs prefer to block channels that are open. Some drugs prefer to block channels that are closed. Some meh are either or, right? So for type 1C drugs, they have a strong preference for activated sodium channels, which means that if my heartbeat is faster, it works stronger. Coincidentally, or not coincidentally, but rather, I guess paradoxically, class 1B drugs actually prefer those inactivated sodium channels. So they're even better used in a tissue that's ischemic. We'll talk about that when 1B comes up. But going back to our type 1C drugs, just know that because of this strong use dependence, the faster the heart rate is, the stronger this effect is, right? Because of the strong use dependence. Okay. Let's check our comprehension. Read the question, take a moment, pause the video, we'll get to it. Okay, so the answer here is a prolonged QRS complex. Because this patient is taking a 1C drug, we know that that is going to strongly delay phase zero, which corresponds to a prolonged QRS complex. Those patients are at risk for monomorphic VTAC, right, as the arrhythmia that causes death. Okay, next question. The answer here is B, opening of voltage-gated sodium channels. This drug, again, is a 1C drug. I mean, it's the only drug we've covered so far. And so what do you see here? The main thing is this delay of this phase zero. This delay of phase zero, right, associated with the opening of the voltage-gated sodium channels. Is this going to have a prolonged QRS complex? You betcha. Take a moment, read the question, pause the video. The answer here is C, QRS interval prolongation. Again, who prescribed this patient propafenone? Propafenone. Who gave them that? Okay, they died of monomorphic ventricular tachycardia because their QRS complex was prolongated because that phase zero slope began to increase. Okay, let's move on. type 1A part of our CAB. Our type 1A is our double quarter pounder, disopyramide, quinidine, procainamide as our drugs for double quarter pounder. Now, this has moderate sodium blockage. However, it has a little bit of potassium blockage as well. And so because of this moderate activity, are we going to get QRS prolongation? You betcha. We're going to have the sloping of this phase zero, so of course we got it. But because of this blockage of the potassium channels, my repolarization is a little bit slower now. And because this is a little bit slower, I've now increased this duration of the action potential. I've also increased my effective refractory period. So, how you to know this is the only class 1 drug type that increases the effective refractory period. Now, recall that I said how this corresponds with the QRS complex. This corresponds with QT interval. So me moving this phase 3 a little bit over here is going to prolong that QT interval. So what arrhythmia are these patients at risk for? Torsade de Pointes, also known as polymorphic VTAC. So you got to be mindful of that. Okay, some specific associations with each of these drugs of the double quarter pounder is that procainamide is an excellent drug for patients with WPW because for those patients that have an accessory conduction pathway, it will slow that down, get them out of that arrhythmia. However, note that an adverse effect associated with procainamide is drug-induced lupus, okay? So you know of another drug that can cause drug-induced lupus, hydralazine, and yes, drug-induced lupus is the same as lupus-like syndrome, right? Those are used interchangeably. Okay, disopyramide, typically only used in HOCM the MVP, right? Hypertrophic cardiomyopathy. Note that disopyramide can cause heart failure because it has negative inotropy. And then lastly, note that quinidine, its major adverse effect is associated with synchonism. Now, synchonism is a presentation of tinnitus. They can have headaches, ring of the ears, vertigo. They might even have thrombocytopenia. Okay, check your comprehension. Read the question, pause the video. Okay, the answer here is C. The only drugs we talked about are ones that block sodium channels, right? This patient has WPW, right? We gave him procainamide, and that is going to block the sodium channels, slow down that conduction, accessory conduction pathway. Let's move on. The answer here is A, phase 0. We know that this patient is having drug-induced lupus as a result of taking this procainamide, right? Procainamide is a double quarter pounder drug, which means that it is a type 1A drug. Regardless, it's a type 1 drug, and so it will impact phase 0, primarily the sodium channels. Next question. The answer here is C. And so what do we got here? This patient is taking disopyramide for hypertrophic cardiomyopathy. And because it's disopyramide, it's our double quarter pounder, which means it is a class 1A type drug. If it is class 1A, we know that not only do we have moderate sodium blockage, we got a little bit of that potassium blockage as well. And because of that, not only are we going to prolong our QRS, we're also going to prolong our QT. And because of that, we're going to prolong our action potential duration. And because of that, we're going to prolong our effective refractory period. The answer here is C. Okay, there's another question if you want to do it. Let's move on. Lastly, guys, come on, we're almost there. We're almost there. This is our last drug subtype, one of my favorite ones too. This is type 1B, which is our LM, right? Our LM, our lettuce and mayo, with a little bit of sobraritos, because we remember that it's mexillatine. So lidocaine is the main one to think about as type 1B. What does lidocaine do? Okay, it's the weakest sodium blocker. However, remember when I talked about that drug dependence there, right? It's kind of interesting because not only does it impact these open sodium channels, it actually kind of has a little bit of a preference for these inactivated sodium channels. So that's what gets this graph here to be a little bit skinny on each side. This phase 3 is going to pull in here. And so what does that do to the QT interval? It actually shortens it. So you'll note here that in most graphs, this phase 0 is not really this far for type 1B. Most textbooks will show this to be actually a little bit closer to here. because it has little effect on the QRS complex. We're not actually going to expect a huge prolongation of the QRS interval. It would be rare for it to do that, but it can, right? In theory, right? Big idea here is that it's going to shorten this QT interval because it pulls in this phase three here because it acts upon those inactivated sodium channels as it does those open sodium channels. Okay. Because of this, it is highly effective in patients that have ischemic arrhythmias. So, what do I mean by that? Let's say you got a patient complains of a substernal chest pressure. You look at the 12 lead, leads 2, 3 AVF. They have a big one. They got a big one, 2, 3 AVF. All of a sudden, they're in monomorphic VTAC. They got the McDonald's golden arches across the screen. What's my drug of choice? I want to get lidocaine. Why do I want to get lidocaine? Because it's good for ischemic ventricular arrhythmias. Okay, how are you going to remember this? Well, this is one of my favorite drugs, right? To give lidocaine. For this type 1B drugs, I like to think of 1B as the bad boys. These are the bad boys. So of course I put myself over there so that you can remember that these are the bad boys over here. Why are they the bad boys? Because they love hanging out with that ischemic tissue. Okay, they love hanging out with that ischemic tissue. They love being extra, doing the opposite of what type 1A drugs do. So what are they going to do? They're going to decrease that action potential time, right? They're going to decrease that action potential duration, right? They're not even great at doing that phase zero stuff. And they try to do a little bit of that skinniness of that action potential because of this phase three pulling in. These type 1B drugs are the bad boys, right? What you going to do? Let's check comprehension. Read the question, pause the video. The answer here is D, right? Ischemia is going to increase the effects of this drug because patients that are ischemic, right, or those tissue that tissue is I'm becoming ischemic. See, that tissue is ischemic. Therefore, it has those higher abundance, higher density of those inactivated sodium channels, which will be bound to that lidocaine, right? And so type 1B drugs are effective in ischemic arrhythmias. Okay, this is a summation of those adverse effects that we've talked about. Here are your highest yield clinical pros to be able to differentiate between class 1A, 1B, and 1C. Okay, recall that class 1A drugs will have the moderate sodium blockade, but not only the moderate sodium blockade, so will it have that prolonged QRS complex? You betcha. It's also going to have a little bit of that potassium blockade as well. And so we're going to prolong that phase, that repolarization phase as well, which will cause the prolongation of the QT interval. So I got a prolonged action potential time, right? I got a prolonged QT interval, and that places the patient at risk for torsades, polymorphic VTAC. That loop you the little, bigger, little. Okay. Our double coda pounder for quinidine, that's associated with synchronism and also thrombocytopenia sometimes. Procainamide is associated with drug-induced lupus, even though it's really great for WPW. Disopyramide can worsen heart failure because of its negative inotropic effect. Class 1B. All right. Class 1B is our weakest. It's our bad boys. Does the wants to do what the class 1A doesn't do, right? So it's going to decrease that action potential duration. It's going to decrease that QT interval because of it likes to hang out with that dead tissue. It likes to hang out with that inactivated sodium channels. It's different. It doesn't even go into the school, right? He likes to do rapid dissociation. So what is the adverse effect? They're toxic. Neurotoxicity, these patients can have tremors, CNS depression. Lastly, our strongest sodium channel blocker, our class 1C drugs, right? Fries, please, right? Is going to cause that giant slowing down of that phase zero. So we're going to have the biggest risk of the QRS widening. So we have a risk of ventricular tachycardia, those McDonald's golden arches. So we want to avoid this for patients that have a history of an MI, structural heart disease, acute coronary syndrome. However, there's no change in action potential duration. Okay, so here's a summary of everything that we just talked about. Note that a lot of what we used here are figures from Ninja Nerd as well as some other resources. So just throwing that out there. If you need some more detailed information, you can watch Ninja Nerd's video, although note that it's about 3 hours long, but we pretty much covered everything that you need to know about those type 1 drugs, which are allegedly the most difficult. But don't worry, because you got all of it. You know all of it. You're smart, you're capable, you're intelligent, you're awesome, you're incredible. And that's all she wrote. All right. Send me a message if you got any questions. Otherwise, let me know if you want videos on the other drug antiarrhythmics. All right. See ya.